and the strength and resilience of the children and adults who have experienced and are still experiencing family violence. We pay our respects to those who did not survive and to their family members, kin, and loved ones. Just a little bit of housekeeping before we get started. So we'd ask that you stay muted throughout the presentation unless you'd like to ask a question. Today, because we're a smaller group, rather than asking through the chat box, please feel free to ask, just to unmute yourself and ask. Otherwise, if you would prefer to put it in the chat box, we will be monitoring that throughout the session. The session will be recorded and will be available on our website if you are wanting to look back on anything that's been covered later on. Also, just please do ensure that you are logged on to your Zoom using the name that you've registered with, just so we can provide you with your certificates for your CPD. And you can do that by, if you're using the app, clicking on your name and clicking on rename. If you're using a computer, a PC, you can hover over your name and click the three dots. If you're using a Mac, you can hover over your name and click more. And once you've put the name in that you're registered using, please click done, change, or rename. And if you're having any issues with that at all throughout the session, please don't hesitate to reach out to me. So you can use this session towards your reviewing performance and measuring outcome hours if you do implement any quality improvement changes, and we will send out a little bit of information about that after this session. Just a little bit of information as well about how you can use health pathways to support your practice with people who are experiencing family violence. So some of you will already be aware that Health Pathways is an online resource developed by Eastern Melbourne and Northwestern Melbourne Primary Health Networks in partnership with health professionals and organisations throughout the region. It's a single point of entry to a rich trove of local clinical information, and you can also use it to claim CPD, and I'll give you a little bit more information about that in a moment. For information about family violence through Health Pathways, you can navigate to family violence under medical assault or abuse on that panel at the left there, to family violence referral and community support, sexual assault or abuse, or physical assault and injury. We have a number of different topics, including disclosure of family violence, that has information on assessment, management, and different priority populations, such as LGBTIQA+ peoples. And there is also a case study there that you can use to boost your capacity to recognise red flags, assess appropriately, and apply evidence-based pathways. There are a number of different pathways that relate to family violence. These are some of them. You can also use Health Pathways to claim CPD. So if you have a look, that's through the panel on the left there, and you can either do it through reporting, or if you don't have your own Health Pathways, if you're using an organisational Health Pathways account, you can self-report, and there will be more information about how to do that going out with these slides. So if you don't currently have a Health Pathways account, you can set one up using that QR code or just visiting that website. And once you've applied, you'll get 10 days access while your application is being assessed, but provided that you're a health practitioner in the catchment, you will then have ongoing access to that. I'll just pass over to our speakers. We have Jennifer Neal, Shay and Martina, and they'll talk a little bit about themselves before they move on to their presentations. Thank you so much, everybody. I'm going to stop sharing my screen now and pass over to our speakers.
Thank you very much, Nikki. It's very lovely to meet you. I'm just going to put our slides up. So just bear with me while I do that. I'll just introduce myself, and then Shay and Martina can introduce themselves. So I'm Associate Professor Jennifer Neal. I'm an academic GP and I'm a family violence educator. I'm Head of Curriculum at the Monash University Medical School, and I've been working with Safer Families for a long time in family violence education. And I'd just like to hand over to Shay, who's going to introduce themselves.
Hi everyone, I'm Shay. I'm a practice lead at Rainbow Door, which is a part of Switchboard Victoria. and I have extensive experience in family violence and LGBTQIA plus advocacy and education. And I will pass on to Martina.
Hi everyone, my name is Martina. I'm a community development worker by trade, but more relevant to tonight's discussion. I'm a lesbian and a mother to an almost 25-year-old son, and we are both survivors of family violence in a same-sex family. And I undertake advocacy work through Weavers at the Safer Family Centre in Melbourne, as well as being a member of the Victim Survivors Advisory Council. And I undertake other survivor advocacy work independently and through the Safe and Equal Lived Experience program.
And I should also mention that I'm an LGBTQIA plus ally with 3 very proud queer children as well. We would like to acknowledge that we're on the traditional lands of the Wurundjeri people of the Kulin Nation and offer our respects to the elders past and present. And we recognise and respect their cultural heritage of this land. We also want to recognise that there may well be attendees here today who've had personal experiences of family violence of a variety of kinds, and we would like to acknowledge your strength and your resilience as well. So we'll just outline what we're going to talk about today. Our focus obviously is on the LGBTQA plus community, and there's a really good reason for that, and you'll see that in a moment. We want to understand the prevalence of domestic and family violence in this community, the drivers of domestic and family violence in this community, how to identify and overcome barriers to identification of domestic and family violence, and using the socio-ecological framework to develop management approaches for this community in primary care as well. So essentially what we're going to do is talk about prevalence of intimate partner violence. A lot of the focus here is going to be on intimate partner violence. We don't have a long time to talk. If we had a lot longer to talk, we'd talk about other forms of violence like sibling abuse, adolescent violence, child abuse, and so forth, elder abuse. But our focus today will really be on intimate partner violence, which is the most common form of violence. And we will be talking about the prevalence of that. We'll also be talking specifically about drivers and prevention, about barriers to help seeking, how to identify LGBTQA plus people who are experiencing family violence, and how to respond to this community as well. Over to you, Shay.
Thank you. So I thought we could start with a little bit of a history and context about the community. I would love if folks maybe want to unmute themselves, and if anyone knows what the acronym stands for, the LGBTQIA plus SB. Make it slightly interactive. No? All right, fine. So this is the acronym that we use for the community. Essentially, the L stands for lesbian, gay, bisexual, trans, I for intersex, Q for queer, A for asexual. SB is a recent addition just to acknowledge the experiences of First Nations, Aboriginal and Torres Strait Islanders, noting that their lived experience of being queer and being part of the community is very different to the rest of the cohort. For, again, just very brief background, the LGNB often relates to folks and their sexual attraction. The T, I, and Q relates to folks and their gender identity, and then the plus is for everybody else. Whilst the acronym is obviously very popular and widely accepted as representing the whole community, not everyone in the community uses it. The community isn't homogenous, so it's always worth noting that if you do meet an individual who presents to your service, try not to make any assumptions, ask folks how they self-identify, because everyone's a little bit different. And I think it's also really important to note the history of the queer community in relation to service, to accessing care, whether it's from the health services, social services in general, service systems. There has often been, or there is a history of discrimination against the community, particularly medical gatekeeping, invasive corrective procedures that didn't have informed consent in them, and a history of like invalidation of people's identities, minimizing of people's experiences. And so that still lingers to this day. Oftentimes the community, there's a significant rate of medical distress within the community. And I think this will add context later on to what we talk about, why folks may not access services for family violence. Next slide. I thought also it might be worth noting some key language and terms that you might come across, such as cisgender, gender diverse, transgender. Basically, cisgender is anyone who identifies with their sex assigned at birth. Trans is anyone who, or transgender is anyone who doesn't. Gender diverse, umbrella term for folks who don't fit within the binary. Brother boy and sister girl, again, these are descriptors used by the First Nations community. Not everyone in the community uses it. I believe it's from the north of the country. And so they're different, depending on where you are. The words to describe people, to describe First Nations trans people might be different, but brother boy and sister girl are the widely accepted ones. Again, if someone were to present to you, it's always often best to ask how they self-identify so that you can have a note of that and use that respectively. Queer is also a general umbrella term for folks in the LGBTQIA+ community. Again, not everyone identifies as queer. Also, a bit of history and context here is that queer was used as a slur word against folks within the community. So oftentimes you will find that folks who are older may not use that term to self-identify or describe themselves. And even some younger folks still don't use it because they maybe want something more specific to themselves, or because they still have the, they still acknowledge the history of the word and how it was used. Again, with the medical distress, if you think about folks from the HIV/AIDS epidemic back in the 70s and 80s, and the treatment that the community experienced during that time, there is a lot of, again, medical distress and just distress of systems in general. And another one of note, which I think is really important and comes into play, again, when it comes to family violence and folks disclosing, is misgendering. And this is the accidental or deliberate use of the incorrect pronouns, name, language, or description of a person that doesn't align with their affirmed gender. It's really important because, again, this is a very easy and often the first point of contact for a service user with the service. And if they are misgendered in any way, it reduces confidence in the service and of a person wanting to disclose. Also, it's important to note that in Victoria, under the Equal Opportunities Act, pronouns, gender, and names are all protective factors. So it's really important that as workers, we're aligning ourselves with the legislation in place to support and respect people's dignity, essentially. Again, sexual orientation, we all know what that is, describing someone's attraction. Gender identity describes how someone might self-identify in terms of the binary or not. And gender expression is how someone may choose to present themselves in the world based on their gender identity or in relation to gendered concepts. It's really important to note that gender identity, sexual orientation, gender expression are all independent of each other, but they can always coexist, but they're not also necessarily interrelated. And by this, I mean, someone's gender identity might not be congruent with their gender expression, and it's not an indication of their sexual orientation. If you think about, say, Rosie the Riveter, or if you've ever watched Victor and Victoria, the musical, these were women who identified as women, cisgender women, who presented in a masculine way or wore masculine fashion, but were still for all we know, attracted to men. So that's a prime example of how these three concepts are very separate, can be interrelated, but can be separate. And it just means, again, encouraging folks to not make assumptions about how someone presents as a means of identifying that person. And also of note is intersex folks within the community. That's the definition there provided by Intersex Human Rights Australia. Intersex is an umbrella term for a very diverse population. You know, intersex variations presents literally in an infinite amount of ways. And so whilst the LGBTQIA+ community includes the intersex community folks, folks intersex folks don't necessarily always identify as LGBT+. And also they can't be conflated with being trans and gender diverse. The lived experience of an intersex person is very different from the lived experience of, say, a cisgender person or a trans person. If you think about the experiences of intersex folks who have corrective surgery, whether it's in their infancy or in their childhood through into their teenagehood, and sometimes that happens without informed consent or choice. You know, a doctor will see a child and make an assessment as to whether or not they fit into a binary and choose the binary of the child. And, you know, it oftentimes leads to a lot of trauma for intersex folks. Also, intersex folks might be heterosexual, like I said. They may identify as transgender or, you know, gender diverse in the future, but it's worth really respecting the lived experience of intersex folks, again, and the dignity of the folks if they present and come to your service. Whilst the LGBTQIA+ community has experienced a lot of trauma in its time, in its history, the community is thriving and surviving, I'm happy to report, and oftentimes by a very beautiful combination of like loving relationships, chosen family, affirmation, whether that be medical, social, personal affirmation of some sort, legislation, freedoms. It means that folks do have a better outcome at life, do have better outcomes when they have support around them. So again, whilst we'll be talking about really heavy things in this presentation, it's really worth noting that one simple experience or one really positive experience with a service provider can really make a difference for LGBTQIA+ people. And yeah, I think it's just, you know, in the current situation, globally, geopolitically, a lot of violence still does happen towards LGBTQIA+ community members. If you think about Queensland and the ban or the review into trans affirmative or gender affirmative care. But whilst all these things happen, the community continues to thrive and continues to exist.
And I want everyone to keep that in mind as we go on to talk about intimate partner violence, that there are some incredibly positive things happening in this community. We are going to go on and just define what we mean by intimate partner violence. So it's referring to any behavior by an intimate partner, but remember also it can be from an ex-partner. It doesn't have to be from a current partner, because often intimate partner violence actually continues once someone actually leaves their relationship, that causes physical, sexual, or psychological harm, and includes physical aggression, sexual coercion, psychological abuse, and controlling behaviors. And really understanding that power and control really underlies intimate partner violence and the dynamic of intimate partner violence. So we're going to go on and just talk a little bit about the prevalence within this community. So I'm not quite sure why that hasn't actually come up with the stats there. Oh, here we go. They're coming up one at a time. So this basically within the LGBTQIA+ community, there is a higher rate of intimate partner violence. And you can see this is recent violence, so within the past 2 years. So for people not in the community, it's 5.1%, and people within the community, it's 13.4% who have experienced domestic violence. And when we're talking about this, what are we talking about? We're talking about all forms of violence, so financial, psychological, spiritual, physical, sexual, coercive control, all forms of violence. We will also talk about the lifetime prevalence of violence. And these figures are really relevant because they are very recent. You can see there, they were actually just published on the 5th of May this year. So this has literally just come out. And we can see that for heterosexual individuals who are over the age of 16, it's actually much higher than we thought. These are Australian figures. So 43.1% have experienced intimate partner violence in their lifetime. But you can see there that those with diverse genders, 69% have experienced intimate partner violence within their lifetime. And for non-heterosexual greater than 16-year-olds, 70.2% have experienced in their lifetime. And this is really reflective of the fact that this community experiences significant marginalization and discrimination. And it's important to understand that. It's important to understand that this is not actually part of the culture of this community, but it is because that they have been experiencing marginalization and discrimination. We'll talk a little bit more about some of the different forms of violence that this community might experience that are different from the heterosexual community in just a moment. Over to you, Shay.
Yeah. Very quickly, it's worth noting La Trobe, Rainbow Health Australia out of La Trobe University and Arches, they do a lot of good work into the research for the queer community, essentially, and they published Private Lives 3, Writing Themselves In, which came out a few years ago, and I think there's a new one now. They've released a new resource guide that I would really encourage everyone to read. And the reason that we're highlighting these specifically is because not the ABS, while it obtains and does some research into the community, we know that there's barriers to access. We know that there's underreporting happening, and the La Trobe have essentially been really forefronting the work in this sector. So obviously there are other folks doing that work, but just, yeah, really want to highlight really comprehensive research from La Trobe. As Jennifer said earlier, the correlation of family violence and, particularly IPV, intimate partner violence, is quite high within the, or for the LGBTQIA+ community compared to, say, the cis heteronormative cohorts. When we think about other intersectionalities such as gender, disability, homelessness, financial income, we see that the rates of IPV family violence increases, particularly amongst trans women being the most impacted by that, followed by folks who are trans or gender diverse, compared to their cis counterparts within the LGBTQIA+ community. Oftentimes, there are barriers to reporting because, I think there's a high prevalence, unfortunately, of vulnerabilities such as homelessness, mental health issues, disability within the queer community already. And so conflated with family violence, there's higher occurrences. And again, like I said, they often go underreported, and they're barriers to access for folks who want to access support. Thank you.
Show you it all. It's easy.
Yeah, thank you. So again, some of the research from La Trobe has shown that, when family violence occurs, it's just really high. It's really high, a really high occurrence. And the fact is that only, for example, here we can see 28% of folks actually report the most incident they have. And that oftentimes means that there's just a lot of violence happening that's not reported, not supported. Only a small fraction of folks actually presents to services seeking support. And it varies within the cohort in the sense of, for example, I think bisexual women only, I think something like 25% of bisexual women will actually seek support, but then sometimes they'll go to a mainstream service versus an LGBTQIA+ service because they think their queerness will be used against them. Again, because of the barriers, discrimination that often occurs, and when folks present, only 2/3 of folks who actually report feel that they're supported when they're doing so. So you can see already that we already have a small proportion of folks who have the courage, the bravery, the means to report, to disclose, seek support, and then a high percentage of those feel that they're not supported correctly when they do so. Again, further increasing folks deciding not to make those choices to support themselves to be safe. Again, I've already said, 35% of folks will prefer to go to a mainstream service than a queer service. That's lots of reasons, whether they feel like other community members will know them, or just because they don't know about the queer services that exist. And of the mainstream services that do provide LGBTQIA+, provide family violence support in general, only a very small fraction of them actually say that they will support trans or gender diverse people. Usually on websites and marketing, it says women and children. And if you don't fall into that bracket, it's really hard for folks to understand what family violence is for the queer community. Again, similar to the other stats, folks are more likely to report violence if they're a cisgender woman, because they are able to access the service a little bit with a little less barriers in place, or a little less apprehension. Again, non-binary folks, depending on their assigned sex at birth, feel that they might be able to access mainstream services, but then they hide the fact that they're non-binary, or experience misgendering so that they can access support. And it's across the board for also like similar figures for homeless folks experiencing homelessness. And however, I think it's safe to say that when folks have a regular GP and support from their GPs, supportive GPs, they're more likely to report and disclose their family violence than if they don't. Thank you. So like I've said so many times, because of the medical, there's distrust in the systems at large, whether that be the legal, medical systems, experiences of medical distrust, or, discrimination of any kind, folks are less likely to either report their violence, disclose it, or even recognize that what they're experiencing is family violence, because they don't see themselves in the narrative of the cishet woman and man. And if GPs services aren't able to also recognize that, it means that we're missing a really significant number of folks who might be needing support. Again, because of the narratives that exist, and the fact that there are not that many inclusive services available, we know that underreporting of family violence is quite high.
I'd like to just ask Martina at this point, as a survivor and someone who's spoken to other survivors within the community about the barriers to help seeking for this community, can you just discuss that with us a little bit?
Yeah, sure. It's actually, and more has been coming up as Shay's been talking. So for me, a lot of it was having to come out time and time again as being a lesbian. So, and then not being believed when when I did speak out, not by my GP when I left my most recent relationship that was family violence, but recognizing that that my poor choices went back quite a few years. And so also another barrier was just the assumptions that the perpetrator was a man, and assumptions has come up a lot tonight already. Being told that the abuse that my son and I suffered was not as bad because the perpetrator was a female, and even being told that I couldn't get help because my perpetrator was a female from a local family violence service, which was really challenging. My emotional needs were often overlooked because my abuser rarely used physical violence. She used coercive control was her main modus operandi, for want of a better word. It's much harder to sort of prove that psychological damage as opposed to seeing a bruise or a black eye. Homophobia and as Shay said, and discrimination, like whilst this was not something I experienced with my GP, I know that there have been people who have experienced that. Definitely limited knowledge by health professionals on where to refer me and my son, especially for support. And when I left, my son was 12. So heading into the teenage years and being a male, it was much harder to get support in a refuge or anything like that because he was nearly a teenage male. I think the biggest barrier, thinking it's just sort of come up in this last 15 minutes, is the fear of losing my son. So when you're living with someone who tells you constantly that you're going crazy, that you're going to lose your child, you know, because you're in this family violence. And for me, my son was born via sperm donor via artificial insemination at home, which was illegal when he was like conceived in Victoria. So there was already a lot of fear of, you know, the police and the justice system and things like that. And then to be told by my abuser that, you know, oh, you can't tell anyone about this abuse because they'll take away your child, which of course is every parent's worst nightmare. So I think that's probably one of the biggest barriers, is that I was not ever going to tell anyone because of the fear of losing my child.
Yeah. Well, thank you so much for sharing your story there, Martina. That's really helpful to hear about that. There's obviously a lot of barriers, isn't there?
Yeah.
Shay's going to talk a bit about the drivers and prevention as well.
Thank you. So yeah, there's a lot of really good resources and work coming out of La Trobe and Rainbow Health Victoria around drivers of violence when it comes, or family violence. And it's all based on, you know, feminist literature, feminist work, policy frameworks, initiatives, interventions that currently exist, proposed interventions. Again, I would really encourage folks to have a look at that, because basically what they found is that the drivers of family violence for the LGBTQIA+ communities are the same as they would be for the cis-het cohort community. It's a lot of the research is, again, you know, born out of a lot of what's the word I'm trying to find, a lot of insight, or looking into a lot of the multifactorial influences of family violence. And so those could be things like societal, thank you so much, societal narratives and assumptions around, you know, binary genders, what it means to be a man and a woman, cis heteronormativity. You know, the women stay at home and they cook and the men go out to work. There's also, again, structural barriers or influences such as, inequality of recognition of queer identities, that they can be different and diverse and they don't have to fit into the binary. And there's also, again, we've already touched on this, kind of organizational and community assumptions and narratives about what family violence is, and also around the LGBTQIA+ community, who is, for example, who is deemed the correct type of human being, or, you know, acceptable to society, essentially. There's a lot of, as it says, devaluation of the queer community's gender diverse identities, what a family looks like, you know, binary or traditional family of a man, woman, you know, and 2.5 kids potentially. So there are all these factors, including individual factors as well, and they all center around the cis-het patriarchal narratives of what people should be, or what society should be, and like what's ideal and what's not. And these continue to drive really high levels of family violence within and towards the LGBTQIA+ communities. It means that, you know, when perpetrators are identified, sometimes they're able to get away with it because the narrative doesn't fit, as Martina was saying. If it's coercive control, it's not seen now it is, but it wasn't seen as bad as physical violence, or wasn't taken as seriously. And we know that it has huge impacts. It can be, you know, the impacts that we've already been talking about can show up in the way of stigmatization and discrimination. When someone does have to try to access a service, their experiences are minimalized or their identities are invalidated. There's a really large interplay of all these factors. And when you think about also intersectionalities or intersectional identities, they all compound on each other. So whilst cishet cohorts and, you know, LGBTQIA+ folks do have the same drivers of family violence, there are niche aspects of it, additional niche aspects of it that that the LGBTQIA+ community experience. Yeah,
absolutely. So now that we understand a bit about the drivers and the prevalence, we're going to talk a little bit about recognizing it in primary care. So I'm just going to give you a bit of an example here. So Rivka and Shannon. Rivka is a 22-year-old cis female. Shannon is a 37-year-old non-binary assigned female at birth. They've been together as a couple for 3 years. And just like often happens in general practice, they come to see you as your GP, but they come to see you separately, because often in primary care, we see whole members of the family. So we actually know them both. So Shannon actually comes to see you and has really bad pelvic pain and has been having really bad PMS, resulting in increased gender dysphoria, reduced mood, is feeling really reluctant to seek help for this reduced mood, and actually almost doesn't really want to talk much about the reduced mood. They are starting to wonder about the possibility of using testosterone because of the gender dysphoria, but they're really concerned because Rivka is strongly against this, and Rivka is not using Shannon's preferred they/them pronouns. And Shannon is finding this really difficult. So I want to just ask you all, are there any red flags here? If this was your patient and you were seeing Shannon, would there be any red flags here that would make you think that possibly intimate partner violence might be occurring? And what would those red flags be? Has anyone got any thoughts? Anyone want to speak up or pop it in the chat? It's okay if you don't. There's a lot of red flags. So I'm going to pop them up on the next slide, but there's even more than this, really. I mean, even just the chronic pelvic pain to me would be a red flag. I'd be starting to think about whether that would be a sign that perhaps intimate partner violence may be occurring, whether there's been any previous sexual abuse or anything like that might be occurring as well. The mental health concerns. Any patient who's having mental health symptoms or depressive symptoms, you need to consider the possibility of intimate partner violence, and certainly within this community. And this patient is obviously feeling quite stigmatized by the concept of, feeling low mood and doesn't want to talk about it. And that's a bit of a red flag as well. So internalized transphobia. So this non-binary patient is actually in of themselves, may actually be feeling transphobic in of themselves, but also may be experiencing externalized transphobia, so transphobia from their partner as well, which is very likely given that their partner's not actually recognizing their pronouns and not actually therefore recognizing their identity, which is really important for Shannon. So you need to be thinking about the possibility of past trauma experiences. And again, that chronic pelvic pain is something that would be a bit of a red flag to me about the possibility of past traumatic experiences. But yes, could this be coercive control by Rivka? The fact that Rivka's not actually possibly allowing Shannon to go on testosterone or recognizing pronouns, is this something that's actually a coercive control picture? And that's something that you'd want to explore a little bit further. So if this was your patient, these are the sorts of things that you're going to explore with your patient. And you are going to ask about whether they're feeling safe. You're going to ask about whether they're feeling safe in their relationship. So in primary care, part of the thing is to be actually helping our patients to recognize the patients who are experiencing intimate partner violence, to be recognizing that their experiences are violence. So for someone like Shannon may not actually be currently recognizing that what they are experiencing is actually intimate partner violence and that they are experiencing coercive control. So helping Shannon to understand that they are actually experiencing a form of violence. And you may or may not use the word violence, you may use abuse, you may use the word coercive control. It's sort of a bit patient dependent on the language that you decide to use. More important than anything is validating your patient and their experiences. So you must believe your patient. you must believe what your patient is telling them about their experiences. So with Shannon, you must believe their own experiences, and tell them that what is happening to them is not okay, and it's not their fault that this is happening to them. Being aware of stigma, so understanding that there may well be stigma even within the LGBTQIA+ community. And, you know, a lot of people think that stigma is something that just comes from, you know, a heterosexual cisgender person, but actually it can come from within the community as well. And I think it's important to understand that. And that can be used to cause a disempowering and to control patients as well. Beware of assumptions leading to perpetrator misidentification. Now, this is a real issue. And I think this can often happen because there's assumptions around, you know, whether, you know, I think that the traditional thinking is that you know, a male is the perpetrator, a female is the survivor. So it's very easy then to think that, for instance, a trans man might be actually a perpetrator, when in fact trans men are very often survivors, and in fact have very, very high rates of being survivors of intimate partner violence. So very important to not make assumptions about your patients. Being aware that victim survivors might actually feel the need to protect the perpetrators. So, you know, remember, there are lots of barriers to survivors leaving, just like there are in the heterosexual cisgender community. There are lots of barriers to survivors leaving their perpetrators. It might be that they still love them. It might be that they think that they're going to change. It might be that, you know, there's children involved in the equation. It might be for financial reasons, that they're worried that they're going to be homeless if they leave. There could be all sorts of reasons. Or, of course, it might be that they actually feel worried that they're actually going to be killed or seriously harmed if they're actually going to leave their partner. And we know that that is the most risky time for a survivor, is actually when they're leaving. So it's very important to take that into account as well. And we'll talk a bit about referrals a little bit later on. So I'll just hand over to Shay now.
Thank you. I've already somewhat touched on this, but and Jennifer has as well, in terms of identity-based abuse and how it's quite unique to the LGBTQIA+ community. If you think about assumptions that are made about, say, folks living with HIV, if you think about assumptions that are made around, you know, what a trans man should be, or how men should be in general, what you find is that not only within the community, as we were saying earlier, you know, the stigma that exists, that means that community members might not be supportive to other LGBTQIA+ members, or might shun them. There's the same experiences that they might also, in addition to internalized experiences, they might experience that from outside the community, from, you know, their cisgendered cohorts and those working within the sector. So it's always really worth noting that, again, a bit of decency, a bit of respect, validation of someone's experiences can really make the difference for them in terms of being able to access support. As workers, we are we're the gatekeepers to support within the sector or the systems. And so it's really important that we are mindful of all the ways that, all the forms of abuse that can happen, especially based on identity, to community members as well. And like we've said already so many times, it really can impact someone's confidence to access support or to leave their relationship, because they're scared of all the discrimination that they might experience once they do so.
And can I just add something? I mean, it's hard enough to leave as it is. So when you add all of these other things on top of it, it just compounds it all. And it's always, people often think it's so much easier to just stay because you've got all of this just layered on top. Yeah, sorry to interrupt, Shay.
No, so fine. And you're absolutely right. Yeah, you're absolutely right on that. And I was going to also say, like, as the slide shows, I think it's worth talking about people using violence, perpetrators of violence. The research shows that oftentimes people who've used violence have been victims of violence as well. They're victim survivors, whether it's in the earlier lives, or even the transphobia that exists today, for example, that was just one example. And whilst violence is a choice, I'm not advocating or supporting violence in any way. I think it's really worth reminding ourselves as workers that folks who use violence have experienced violence and they don't know any different, or like they've been conditioned that this is how things operate. And so if we're not able to intercept that conditioning, that narrative, violence will just keep perpetuating itself. So again, it's really important where we recognize violence, if disclosures have been made, if folks come to you saying, hey, I think I'm slightly abusive, or I'm really worried about my behavior, my partner has said something, it's really worth recognizing that and supporting folks to access support for that. It can really be the difference for both individuals involved in the dynamic. Yeah. Or even just the children as well.
Yeah,
sorry, go on.
No, Shay, you go.
Oh, no, I think I was finished. Sorry, I wasn't sure if this is my slide or yours.
Oh, well, it doesn't, either of us can talk on it, but I think what's really clear here is that we actually need to take into account all aspects of a person. So there are other aspects of a person that may make them more vulnerable. And we need to consider, for instance, migrant and refugee communities. So that's why, recent arrivals, conservative religious backgrounds, they could potentially experience things like conversion therapy, which has now been outlawed, but in fact, it still sort of happens behind closed doors. Forced marriages, for instance, family assaults, exile within the family, honor abuse, corrective assault, and so forth. And I think you can just see here this quote from a lesbian who says, I have been bashed by a family member for shaming the family. Talks at family gatherings have been gay, lesbian, queer is due to corruption of the West. The imam and sheikh claiming that the death penalty is the punishment for GLQ. And you can see there just what they're up against. So, you need to actually really consider all aspects of a person's life. And that's what we mean by being intersectional, looking at intersectional influences. It's really understanding what are the other things that might actually make a patient more vulnerable. And we also need to understand that within the LGBTQIA plus community, that there certainly is an increase in suicide and suicidal ideation. And I think what's really clear here is that trans men and non-binary people, trans women, have much higher rates of suicidal ideation. So I think, that also needs to be taken into consideration. And when you're doing a risk assessment, it is important to actually also be asking about suicidal ideation as well. So this is really talking about LGBTQIA plus people who've completed suicide, talking to their families. What were the things about that person that made them more likely to complete suicide? And they were things like lack of acceptance by families of origin, lack of acceptance of self, so like internalized transphobia or homophobia, dissatisfaction with physical appearance, physical or sexual abuse, anxiety and depression, more substance use. So these things also, you need to also be aware that these things may make someone more vulnerable to suicide, including things like physical and sexual abuse may actually increase their risk of suicide. So please, when you're doing a risk assessment around intimate partner violence, please also think about the risk of suicidality as well. So just thinking about barriers to help seeking, and Martina's talked a little bit already to us about barriers of help seeking. We're going to go back to Shannon, who was our patient that we had earlier. So barriers for this particular patient, Shannon has never sought help for gender affirmation before, has had negative experiences with other GPs and emergency department care. And Martina mentioned that she'd actually had a good experience with her GP, but she knows of other people within the community that have certainly had very negative experiences with their own health professionals as well. Also, Shannon is not considering themselves to be within an abusive relationship, which is certainly a barrier to Shannon actually accessing care or actually accessing supports or referrals or anything like that. Their non-binary friend advised them not to trust GPs as they always gatekeep and want to keep people to be binary. And so this may actually be a real issue. Because there may actually be health professionals out there that do hold those sorts of attitudes, and that may actually be a barrier to care as well. So it's important to consider that. And as health professionals, it's really important for us to accept the identity of the patients that we have. And so, yeah, Martina, did you want to add something?
I just wanted to add, Jennifer, that probably the biggest issue I've ever had when presenting to, say, emergency or anything like that for anything has been a health professional's assumption that the person with me is either my daughter, even though I'm 5 years older than her and not 25 years older than her, or, you know, my someone that's not my partner. And so I guess for me that that comes back to the assumptions, and just remembering that you don't need to say, oh, is this your sister, your mother, your cousin? You just need to say, oh, so who have you brought with you today?
Yes.
You know, because that's something that's definitely put me off ever attending ED and stuff, because I don't want to have to explain who the person is.
Absolutely. And I think you actually raise a really important point here, because it's actually not uncommon for partners to come in together. And as health professionals, we need to actually ensure that if we're going to ask about the possibility of intimate partner violence, we need to make sure that our patient is alone, because it's actually not safe to ask if the potential perpetrator is in the room, because it could actually put the patient at risk. So making sure that there's a way to see the patient alone. So it could be that you say, look, I always like to see my patients on their own. Could you just wait out in the waiting room for me? Or it could be that maybe the patient's due for a cervical screening test, or, you know, something like that. There could be a way to make sure that you actually see the patient on their own, so that you can ask them, but you cannot ask them if the partner is actually in the room at the same time. So just in terms of barriers, look, we've talked a bit about barriers already, and I would like to read this quote, because I think it's important to really have the voice of survivors. So this is a lesbian parent. So I guess it's partly systemic, that the system doesn't accommodate for diversity. There's also that workers or professionals aren't aware of the different kinds of issues that might arise in an LGBTQIA+ family. So there's an assumption that everyone's heterosexual, and that everyone will function in a heterosexual world, and that, you know, all the services that you refer to are for heterosexual people. All the stats we have, all the data we have, all the studies we've had done, they're all done on heterosexual people. Now, actually, fortunately, that is changing a little bit. We are actually starting to see a lot more studies and data being collected around the LGBTQIA+ community, but I think there is often an assumption on behalf of health professionals that we're dealing with cisgender heterosexual people. Again, just another quote from a queer transgender woman. But I think where I've seen or experienced violence in an intimate partner relationship, because if you're both queer or you're both trans, you're both trying to survive in a world that wants to kill you, basically. And by exposing your partner, even if they're being abusive or violent towards you, by exposing them to interactions with police or the criminal legal system or prison, it could basically be the death of them. And it's far worse than the sort of abuse or violence that is being done within the relationship. So just talking about responding then in primary care. So we've had a disclosure within general practice. What are we going to actually do? First of all, the most important thing is to make sure that our practice is a practice that is inclusive, so that people from the LGBTQIA+ community feel comfortable coming to that practice in the first place. And there's actually lots of things that you can do around this, and it's much more than what is just happening in the consulting room. What is happening in the consulting room is really important, but actually you need to get to the consulting room in the first place. So it needs to be clear from the word go. So, from the website, from the door of from the practice, you might have a flag or a sign or a label or something like that that says this is a place where we welcome people from the LGBTQA+ community. It comes at reception, where assumptions are not made, where people respect pronouns, where people respect names, on paperwork, where people respect pronouns and respect names, and of course in the clinical encounter, where people's identities are affirmed. And then in referrals that are made, it's very easy without thinking to write incorrect pronouns on referrals, and it's very, very important to your patient that you actually get this correct.
I just quickly like to add to that very quickly. For referrals as well, I think it's really important to note that, the system automatically generates all that information. It's worth checking in with your patients to make sure that they're comfortable with whatever information you're sharing to be passed on. Because again, we don't know beyond you, we don't know what the next practitioner is like. We don't know the safety that's available to your patient there. We also don't want irrelevant information like what hormones you're on going to like a physio, for instance. So I think it's just really important to have that informed consent. And also noting things like if there's going to be mail sent out, where is safe, just so that whether it's a perpetrator, whether it's family or an intimate partner, they can kind of safety plan around that, or even, offer different options.
Yeah, I think that's a really good point, actually. And also remembering that some patients still have their dead name on their Medicare card. So their dead name is essentially their old name before they've changed their name if they're non-binary or trans. And it may well be that they've got their dead name on their Medicare card, so that still has to be used on documents. But make sure that you change that in the text of what you're actually writing and make it clear that that's actually their dead name and not their preferred name, and speak to them about what they'd like and prefer. These are some signs that you might use in your waiting room. We've talked a little bit about all these things already, about reception and really making sure that you're using correct pronouns. You can train your staff. You can look at your medical software. Medical software these days is reasonably good at making sure that it actually has a section for pronouns, but and preferred gender. This is just an example of a patient registration form, but these days, look, there are actually so many different identities that are not actually listed here. So it's really important that there is actually an open text for patients to actually put what their gender identity is, because it may well be that it's not one of the ones that you actually have on your form. And in fact, the pronouns may also not be correct either. So identification of LGBTQA+ identity within the consultation. Look, I think it's just about being respectful, really, isn't it? I mean, it's really just being about being respectful and just saying to someone, what pronouns would you prefer? What name would you like me to use? Make no assumptions about who the patient's partner is and what gender that the patient's partner will be, who they're living with. They may actually have multiple partners that they're living with. I've certainly got patients like that who've got multiple partners who are multiple genders. So it's very important not to make any assumptions about your patients. So when we're dealing with Shannon and Rivka, so we've got Shannon, affirming Shannon's gender is going to be really important, affirming Shannon's identity, and then offering support and referral. So we've validated our patient, we've enhanced safety by doing a proper risk assessment and safety planning, and that's a whole other talk, so we're not going to go into that. That's in the Safer Families program, so if you've done that, you'll have covered that. But we'll talk a bit about referrals in just a moment. But also we deal with Rivka too, because Rivka is actually one of our patients, and ideally we would not then be actually seeing both Rivka and Shannon, because actually that could potentially put us in a difficult position, because we might actually accidentally not be confidential and say the wrong thing to Rivka that might put Shannon at risk. So ideally we wouldn't actually be dealing with both partners, but understanding Rivka's perspectives and fears, and making sure that we, that's if Rivka is aware that Shannon has actually disclosed and Shannon's happy for this, you might then offer perpetrator supports and referrals to RIVCA as well, if appropriate. So facilitating the identification of intimate partner violence, we've sort of talked through this already to some degree already. Really, it's important to ask about general experiences of homophobia, transphobia, and stigma. Talking about community connections, I always like to talk with all my intimate partner violence patients about supports and who they have in their lives, because the more supported a person is, the more likely they are to be safe and the more likely they are to be actually potentially able to get out of the relationship if that is their wish to do so. And remember, we must respect wishes. We're not telling someone they have to leave the relationship, but supports are obviously really important. And understanding what help they've actually already sought and really understanding what strengths they have. What is it that they actually have already? What is it about them that they have already that is actually supporting them? And I won't go into lives in great detail because you will have covered this if you've done the Pathways to Safety program, but it's just a good reminder that when you are responding to a disclosure of intimate partner violence in this community, it's no different than in the cisgender heterosexual community, to listen to your patient, to believe your patient without judging, to listen with empathy, to inquire about needs and concerns, remembering that these are the patient's own identified needs and concerns, not necessarily what you think their needs and concerns are, because those two things are often actually different, but actually what the patient identifies as their needs and concerns, and to validate them. When we talked a bit about that earlier, and assuring them that they're not to blame for the abuse is really important. Enhancing safety is important because we know that there is a risk. So there is a risk of harm. There is a fatality rate to intimate partner violence. There is a morbidity rate to intimate partner violence. We also need to consider the possibility that children may be involved. So we want to ask about whether any children have been exposed to violence or have been subjected to violence. And of course, depending on what state you're in, you would then decide whether or not a mandatory report of children would need to be made, but that would obviously depend on whether it fulfilled the requirements of that. Or if it didn't fulfill the requirements, whether you'd consider, if the child was still at risk, whether a referral to a vulnerable children's organisation might be useful as well. But in terms of enhancing safety, the experts in enhancing safety and doing risk assessments and safety planning are family violence workers, and we have to remember that. So if you had a patient who had a kidney disease, you would send them to a nephrologist. If you've got a patient who's going through intimate partner violence, you send them to a family violence worker. It's the same thing because they're the experts in this. We can still enhance their safety while they're with us. We can still, and by doing that, the first and most important thing we can do is actually ask about their own perception of their own safety, because that's the most important thing, because it's their lived experience. They're more familiar with the perpetrator's behavior than anyone else. So they know more than anyone else whether they're feeling safe at the moment. So asking about that is really important. But we're going to go on and talk about supports in just a moment. But as we do, I'm going to get Shay just to mention MARAM and the information sharing schemes, which are specific to Victoria.
Yes, exactly. So the MARAM is the multi-agency risk assessment tool, and it's basically used across all services in Victoria, whether that be specialist family violence services, GPs, hospitals, education settings, to ensure that the victim survivor doesn't have to be re-traumatized by repeating their story if they get referred on, for example. It ensures that their narrative, their experiences are captured properly, and that a thorough risk assessment can be completed, and it also supports their safety planning. In Victoria, with the FIS, which is the Family Violence Information Sharing Scheme, and the CIS, which is the Child Information Sharing Scheme, everyone's appointed an entity, whether a risk assessment entity, information sharing entity, and have responsibilities to complete the MARAM to different varying levels. But essentially, everyone has a responsibility to identify and support someone's safety if there's intimate partner violence or any kind of family violence being experienced. With GPs and nurses in healthcare settings, you are information sharing entities. You can share information, relevant information, to police, the specialist family violence services, to other healthcare workers, if you believe that it would be useful in risk mitigation or safety planning or safety management. So it's always worth noting, getting familiar with the MARAM, being able to complete one. You only need to do a brief one, but it just means that we have the information as family violence workers that we need to support folks when we get the referrals from you. Yeah.
And just before I ask Martina to tell us a bit about what survivors want from their GPs, I'll just mention a management approach using the socio-ecological framework. And I guess that the point of this framework is that so often we're just focused on the individual level, and we've talked a lot about the individual level already today, a referral to LGBTIQA plus inclusive services and so on and so forth. But remembering also that we can actually advocate within our society for inclusivity. We can challenge gender stereotypes within our society. We can just make sure that in all the things that we're doing, that we're using people's correct pronouns and their preferred names, and actually affirming their identities. We, at a systems level, we can be inclusive and really understand anti-discrimination legislation, make sure our workplaces are places that people from the LGBTQA plus community will actually feel welcome. So think about your practice, your workplace. If you had a staff member from that community, do you think they would actually feel welcome? Do you think they would feel comfortable to disclose that they're from that community? Is that somewhere that they would actually feel stigma or not? It's really about being trauma informed, really, isn't it? And so that's really at that organizational level. So having policies at an organizational level, and that comes down to a lot of the things that we were talking about already, about making sure that, reception has, policies around documentation and talking to patients and so forth, and supporting our staff. I would like to ask Martina, though, just to chime in now.
Yeah, thank you so much, Jennifer. And I will say this is my pie in the sky wish list. I am more than aware that GPs have a lot of things to consider when they're seeing their patients, and it's a bit like teachers. You can't be on top of every single thing. But ideally, what I would like from my GP is to be seen and heard and believed, which both Jennifer and Shave said. I want to be given the time, especially if I'm opening up about something as serious and traumatizing and challenging as family violence. It's not a rush job. It's not something you might get out in the first time, someone mentions it. I want to be given relevant and helpful information on what to do next. So what help is out there, particularly as a lesbian woman with a son. I want my son to be seen as a victim in his own right, and for him to be offered support as well. I want you to use my correct pronouns, as we've said, and to ask questions if you're unsure. We would rather that you ask questions than to just make assumptions, so don't make assumptions. We want you to be trauma informed, and we also to be aware of some possible pre-existing barriers to care that might have already been discussed prior to, just before, in relation to why we might not have come to seek help. For some of us, as was said before, particularly our older LGBTQIA plus community members, it hasn't always been safe to be out, so tread gently. And finally, as a GP, you're in a very privileged position. You're a trusted member of someone's community. If a patient comes to see you and their partner is always with them when they come to see you, or your patient seems afraid of their partner, or their partner answers questions for them, they are all red flags. So make an excuse, as Jennifer was saying, to have time with your patient alone and ask the question about whether they feel safe at home, because that could be life-changing and life-saving ultimately. So that's my wish list.
Thank you. That's an amazing wish list. I love it. Shay's going to talk through some of the referral options that we have.
Yep, and I'll be very quick. And in regards to, I guess, police and legal police intervention. Folks oftentimes will not feel safe going to a, run-of-the-mill police officer. And so the Australian government has introduced the GLOWs, the Gay and Lesbian Liaison Officers. They can take statements, they can make reports, they can advocate, they can go with the victim survivor to a station and file the reports, access IVOs. It's a really good one to know. Q-Life is a nationwide service. It's a peer-led service. Folks can call up for advice, talk about whatever they need. Rainbow Door, where I work, is a specialist service in Victoria. It's free. We're able to support folks with case management support, brief intervention, ongoing referrals. There are services out there that can do this work, and it's really good to know what's out there so that you can refer folks or you can make your referrals yourself. Again, say out loud, online resource, folks can access those websites, get some information, victim survivors themselves can get information about how to keep themselves safe or their friends safe. Yeah. AIDS councils in most states as well. In Victoria, it's Thorn Harbour. In New South Wales, it's ACON. They often have their multimodal services, where it's like AOD care, clinical care, peer education type stuff, family violence services. Again, really helpful. Also able to do outreach and help promotion, which is really, really important for the community. For users of violence in Victoria specifically, we've got Drummond Street Queer Space and Thorn Harbour's Behaviour Change Programme. And these offer support to folks using violence or who want to change their behaviour. They're groups specifically for LGBTQ men or LGBTQIA plus, LGBTQ women, trans women, specific groups, or trans men specific groups. It's important to note these are highlighted because if you think about trans people, gender diverse people, even just a cisgender gay man or woman, they can't access normal, I say normal, but mainstream behavior change programs because those are geared towards cishet relationships. Those are geared towards violence towards women. What happens to a woman who's using violence? Where does she go? She doesn't have that option in the mainstream, not really. If you're a trans woman and don't feel safe because you've experienced transphobia from straight cishet men, you're not, and again, that's already a bad referral, telling a trans woman to go to a men's group, but then how will she feel safe in that group? Same for a gay man. If they're talking about their partner and they experience homophobia within the community, they're not going to feel safe opening up about their behavior, or even about changing it, because they already don't feel that sense of personal safety being in that space. So if we can reduce the barriers, if you folks are able to know referral points for victim survivors or users of violence, it can really, again, as Martina said, be a life-changing impact for those experiencing family violence or using family violence. Yeah.
And I think too, if a man presents to the orange door, they don't get, if they're the survivor of family violence, they don't even get through to the next section. So it's really important you refer them to preferably like the Rainbow Door, where they're actually going to be seen as the survivors and not misidentified as the perpetrator.
Yep. Agreed. And there are other resources you can access, whether it's for trans gender affirming healthcare. OzPath is a really good one. Trans Hub is a good one. For intersex folks, Interaction is also a really good one. I was going to say along the lines of, say a victim survivor accessing support from the systems. It's really, even just a straight man accessing support from the systems is really hard. So again, it's really important to note these referral pathways, whether it's for, gender affirming care, family violence, they're all interrelated usually, because it's all part of the identity-based abuse. It's all part of the systemic structural barriers that exist for victim survivors. So really, really important for folks to be aware of what's available out there. The services are limited. They're quite small. Usually, they're small teams for a state, for example, but they will try their best and they will do their best to support folks. And if you can provide some holding support while they're waiting to access those services, again, it can really be significant towards ensuring someone's safety and even just reducing the risk of lethality and imminence. Yeah. Again, I'm sure you folks may already know, there's OzPath, there's LHA, which is the LGBTQIA plus Health Australia, there's Rainbow Health Australia. They provide training, Rainbow Tick training, all sorts of trainings they can tailor to your needs. And I would highly recommend them. They're all really lovely folks. I've worked with folks from all those services. Yeah. And yeah, Rainbow Health Victoria or Rainbow Health Australia have different programs which are really great for whether it's capacity building, advocacy, research. We've already talked about, you know, their work with La Trobe, how to provide inclusive practice. I would really, really recommend them. Again, all lovely folks to work with. And I believe free training, some of them.
It's good to also remember that the RACGP White Book is free and available online. So this is the RACGP's guideline on abuse and violence working with our patients in general practice. There is actually a chapter for LGBTIQA plus people who are experiencing family violence, amongst other things as well. So that's also a really great resource to look at. And it also has a section on referral resources for each state as well in it too. Safer Families have some e-learning modules, and they do have a specific e-learning module for recognising and responding to LGBTQA plus people impacted by domestic and family violence, which is a great module as well. You can also check out the Safer Families Toolkit, which has a number of different tools that may be useful in your practice, and the RACGP has done a number of webinars that you might find useful as well. So that's all the specifics from us, but if you do actually have any questions, Shay and I are happy for you to email us if you have any specific questions about any of the content of today. But I'm going to stop sharing the slides because we'd be really keen to take any questions from anyone. So there's plenty of time for questions. I'd also love to hear a bit more from Martina as well, if anyone has any questions from Martina.
Yeah, happy to answer anything.
Martina, I'm just wondering if you can tell us a little bit about conversations you've had from other survivors within your community about access to healthcare and how that's gone for them.
That's a very good question. The majority of the time, the people I've spoken to have had very positive experiences with their access to healthcare. I think that things have changed a lot, especially in the last sort of 10, 15 years, or even 20 years, you know, with the and with the marriage equality and all of that sort of stuff has really changed a lot of people's attitudes. But in general, I think, you know, they've found that practitioners or GPs are much more informed about, you know, the queer community. I use that term with love, and being inclusive and you know, not making the assumptions. I feel like in some respects the paperwork has taken time to catch up. So, you know, filling in forms that will often say mother and father, you know, and all of that sort of stuff. So it's that sort of stuff has taken a long time to catch up. But in general, when you're dealing with someone one-on-one, they've all been very positive experiences. And the same dealing with psychologists, well, you would hope so, especially, you know, and yeah, you know, in general, I think it's been really positive. You get your odd sort of people, but the word spreads pretty quickly in our community if somebody's not, you know, not very inclusive or whatever. And yeah, so I think also it depends where you live. You know, if you're regional, you have much less choice in who you can access for your care. Or, you know, if you're in like if you're in the middle of St Kilda or South Yarra or Northcote, you're pretty much guaranteed to get a queer friendly GP somewhere. I'm out at East. I'm very lucky to have had, you know, very positive experiences. But yeah, I do think that it makes a difference where you're located and how much access you have. in general to, good good practitioners.
I think that's a really good point, highlighting the barriers for rural people, because I think that's actually quite significant. And also the stigma that some rural people might actually experience, because they can be very small communities.
100%.
Yeah, absolutely.
Yeah. Yeah.
And, they may well even know the police officer who might know the perpetrator, who, it can be very complex, can't it?
Correct. And sometimes the police officer is the perpetrator.
Correct.
That's often, a big issue. Yeah.
Yeah, for sure.
Especially in the queer community, I've come across that. Yeah.
Any other comments, Shay? Anything that you want to add?
No, I was going to actually ask you potentially what you, in your research, in your time, in your work, what would you like, what if there was one thing you could impart to everyone, what would you say? What would the thing be? I'm very curious.
Yeah, well, so a lot of my research is based around lived experience. And the thing that I find most when I talk to people is that they just want to be believed. And I think that's the same for anyone who is a survivor of abuse and violence. And I think it's the same for anyone from the LGBTIQA plus community. They want to be believed and accepted for what they're saying. And I think that that's so important for us as GPs. If someone says to us that they have been abused, we need to believe that that's what's happened to them. Yeah.
I actually had a bit of a question and a comment, and you, of course, don't have to answer it, Jennifer, but as a parent of 3 children who are members of the LGBTQIA plus community, and obviously who are, younger, because you're not like 100 years old. So, like, I think this generation, like my son's generation and our children's generation, are far more gender affirming and far more open about everything. And and so I'm wondering whether you feel hope as our children are growing and going through parenting or families.
100% I do.
Yeah.
My kids just get it.
Yeah.
I mean, like they really do, and their friends do, and their friends don't care less that my kids are, I've got a lesbian, queer, and non-binary child, 3 children, and their friends can't care less what their pronoun. I mean, like they care as in that they want to use them, but they don't care. They just accept whatever identity that they say that they are or who they are. And I feel like it's actually the older generation that we seem to find it more difficult. Whereas the younger generation, it seems to come really easily to them. And it's even things like using the right pronouns, it just seems to come really naturally without them having to really think too much about it. Whereas I talk to a lot of doctors who actually find it quite difficult to actually use the correct pronouns, not necessarily because they don't want to. It's not because their heart's in the wrong place. They actually just find it really doesn't naturally, come to them. So yeah, I think I do feel a lot of hope for the younger generation, that things hopefully will improve and that there'll be less stigma, and that absolutely.
Yeah. You've got to feel hope. No, I was just going to say, you've got to feel hope, because the world's a very messy place. So
yeah, that's right. Yeah.
I was just also quickly going to add to what you've all both said. So, like, I know it can seem scary, when you're not familiar with something, whether it's pronouns, chosen names, identifying family violence. I think it's okay to ask questions, and we don't expect you to know everything, and we don't expect you to be perfect. It's, we see when you try, we feel it when you try,
exactly.
And so we will absolutely, you just quickly correct yourself and say, oops, sorry, I used the wrong name, I used the wrong pronoun, and carry on with the conversation. That it takes the stress, the minority stress, off the community member to kind of educate you or to, but unburden you. That's, and especially in a family violence situation, they're already carrying so much. So it's okay to make mistakes. I think it's okay to not know everything. I think it's also, I think just recognize that, yeah, validation is key, essentially. I had a few other things I had to say, but I'm conscious of the time, so I will stop.
No, I think that's a really great point, Shay. I actually do. And I know when I'm talking to people from the community and with my kids as well, that they know that I'm trying, and sometimes I will get it wrong, but I correct myself, I apologize, and they know that I'm actually wanting to do the right thing, and they're quite accepting of that. So yeah.
And we're human, right?
Yeah,
Yes.
that's right.
We make mistakes.
Yeah.
So yeah.
But I think we might need to wrap up now. So I'll hand back over to you, Nikki.
Thank you so much, Jenny, and thank you, Shay, Jenny, and Martina, for such a wonderful session. That was just fabulous, and I think I certainly have come away learning so much. So, really appreciate that. So, just to wrap up the session, just a few little admin details. So, we'd really appreciate you completing our little survey about how the session's gone, so that we can take that forward and hopefully improve for the future sessions. We have this QR code. I've also popped a link in the chat, and this will also go out in a post-session email. You'll receive that within a week, and it will have the slides and resources that have been discussed during this session. Your attendance certificates will be with you within 4 to 6 weeks, and we'll have your RACGP CPD hours uploaded within 30 days. We have lots more sessions, so please feel free to visit our events webpage. There's listed there on the screen if there's anything else that might be of interest to you there, and we will have this session recording up on our website as well. Thank you all so much. I think that probably concludes our session.
So